Welcome to Black Health Matters. I'm Daryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
We have members, a number of our members on the calls who have had falls and have broken wrists and other parts of the body. So it's very timely to discuss this subject. Okay, if there are no other comments, we can go to the next one. And this is one for preparing for medical emergencies at home, subject that we tend not to even discuss at all. And it's something, medical emergency happen at any time and become more frequent as we age. And so it's important to be prepared for medical emergencies because they occur whether you like them or not, and whether you're ready for them or not. And so you ought to have a plan so that everybody in the household understand what should happen in case there's an emergency. And emergency means something that's unexpected. And so who would you call? Who can help you? What numbers do you call? What do you know about first aid? What do you know about CPR? What do you know about wound care? What about the Heimlich maneuver? And I remember on our first cruise, my wife was choking and I had to use the Heimlich maneuver to save her life. So understanding what to do if somebody's choking. See, how do you do CPR? This is something that you need to learn how to do, and it's something that you can be trained to do. American Cross has training courses to teach you how to administer CPR and train you to use the automated external defibrillator, which when the heart stops beating and you are ventricular fibrillation, an AED can save your lives. CPR and AEDs are life-saving measures that anyone can learn and apply. You don't have to be a professional. As a matter of fact, the less professional you are, the more easy it is for you to learn how to do these things. They're very simple. Make sure that you have a working smoke detectors, and if you have fire extinguishers in your house, that's even better. And then make sure your emergency medical information is updated and easy to find, whether you put it on a refrigerator or in your wallet, because the important things that you need to share are your own medical history, your own medication list, what allergies you've seen lately. People die from peanut allergies and other allergies. Do you have EpiPen with you? Contact information for doctors and pharmacists, emergency contact information for who to call in case something happens to you, your blood type, whether you want to be an organ donor if you should die, who is your healthcare power of attorney, have you done your advanced medical directives, which we talked about, and then HIPAA release forms. In other words, who's going to be responsible if you can't take care of yourself? And then who has your insurance information? And then if you have any serious allergy or medical conditions, do you need a medical alert ID bracelet or necklace so that in case somebody finds you, they know what to do? Also, do you have an alert mechanism so that somebody can be called? Make sure your home is clearly marked so that they can get into your house if they need to, if something happens to you. How do you do that? There's a number of ways of doing it. A lockbox is one way of doing it. Leaving the key in a special location that everybody knows about. Then have a personal emergency response system, something on you that can help prevent injuries from falls, or when you fall, somebody can be notified by pressing a button. So key features of medical systems are that people have in their homes, so that if anything happens to you, that these alert systems can alert people immediately with either with a help button or two-way speaker. These are things that if you're incapacitated, then pressing the button can call a live operator, or all of the best medical alert systems, which many of us are not familiar with, offer 24/7 monitoring. And having those, particularly if you live alone, become important. Having water-resistant equipment is important so you can go into the shower and have these things and still, if something happens to you in the shower. And the coverage uh, ranges from 400 to 1,400 feet, depending on the system. The automatic fall detection systems that they have, and I don't know how many of us have them, but especially if you're living alone, it's a good idea to have them. And if you have a relative of yours who lives alone, it's a good idea to have these medical alert providers. And then mobile apps that if something happens, and, and identify any abnormal pattern that could indicate a health issue. GPS tracking is something that is available nowadays, as well as we mentioned before, the lock boxes that have keys to your house. So if something happens to you, they don't have to knock, they don't have to break open the door. Although all you have to do is call the police, and they will open the door if somebody does not respond, as has happened many times with some of my friends who lived alone or found down at home. But these are things that I've shared that most people don't talk about, and so it'd be good if any of you have any questions or comments about some of them, because we tend to uh, not think that emergencies are going to happen to us, but they happen to all of us, and so we need to be prepared for the unexpected. Any comments or a question? Lucy, Dr. Perez, pardon me. Happy New Year.
Lucy's fine. Happy New Year, everybody. One thing that wasn't mentioned that I've done, and that's pockets. Everything I have now has to have a pocket for my phone. So I don't go anywhere without being able to put my phone in my pocket. And in terms of having a digital record, to the best of my knowledge, every phone that's on the market for at least the last 10 years has some place for your emergency information that healthcare providers, those first responders in the ambulance, the police, they can open your phone to your health information. And so wearing something that has a pocket. I used to be concerned that the pockets added inches to my hips, but now I don't care.
Boy, that's a very important message you shared, because men take advantage of the pockets we have in our jackets. But if you don't have pockets, then you have a problem. So thank you for sharing that. That's a very good point about pockets, because you in the old days you wanted to be handsome and pretty and cute, and so you wanted to show off your body. But it's important to have pockets so you can put these things in. So if anything happens to you, you can be taken care of. Thank you so much for sharing that. Any other comments or questions? Safe safe ways of doing things that we didn't mention in this article. or any questions or comments about things that we did mention? Well, it's something that is very important because it's really discussed, and it's something that you know. Sometimes people think that CPR requires you to be a medical person, but CPR and using uh, the automated external defibrillators are easy to use because they actually have all the instructions there. And many lives could be saved by people who just drop down. If somebody could do CPR, and if after CPR is ineffective, they can use a defibrillator and save lives. So keep that in mind. Okay. And if there are no other questions, then we can go to the next article. Any other comments? Yes, John Buchanan.
I was just wondering, maybe we could have a show of hands. How many people have been trained on CPR and AED? I'm one. As a scuba diver, I have to know how to do both of those. And it it takes, some repetition, to get used to doing it. The AED, but they're pretty simple. But a couple of important techniques, uh, staying alive, with the CPR. I was actually bowling one time, and somebody had a heart attack at the bowling alley while they were bowling. And a couple people went over and did CPR and saved this guy's life before the EMS got there to take over. But it's definitely life saving. Everybody should try to get it if you don't have it yet.
And one thing that used to be that you had to do mouth-to-mouth resuscitation, but the new AD guidelines indicate that mouth-to-mouth resuscitation is really necessary. That if you do the CPR appropriately, the rest of it will come into play. Any other comments or questions? It's very important, timely information. Thank you for sharing, Mr. Buchanan. Any other comments? If not, we'll go to the next article. Very simple, just eat more fiber. Very simple title, but it's a timely message that says that one of the most important things you can do if you don't want to do a whole lot of dieting is to just eat more fiber, fruits and vegetables. Simple, peanuts. Those are the things that make a difference. Fruits, vegetables, and peanuts increase fiber, and increased fiber improves your health. You have less allergies. You have healthier intestines, and it's amazing what you can do by just eating more fiber, more apples, oranges, bananas, peanuts, uh, and green vegetables. And so this article just points out if instead of eating some of the things that you want to eat, you add to that the fruits and vegetables and legumes, peas or peanuts, nuts. Uh, these things also increase your likelihood of having a good bowel movement every day and increase your lifespan. So that's the long and short of this great article, which points out that this is very important to do. Eat more fiber, whether or not you go on any diets or not. You were going to do one thing and didn't want to diet. Eat more vegetables, fruits, and nuts. Any other comments about this simple article that can be life-saving? It's not just for people who are overweight, it's for people who are any weight. Apples, oranges, corn, uh, those things really help. Any comments on this very useful, simple article? Eat more fiber.
I like pears, and I can go all the way back up to the top. My favorite fruit is in the picture there, raspberries. I love, love raspberries. It's my favorite fruit.
Yeah, well, it's great fruit. Yeah. Okay. There are no more other comments. Let's go to the next one.
How do you keep raspberries fresh?
You eat them real quick.
Okay.
I don't think I've ever tasted a raspberry. I have to try one sometime. Yeah.
Oh, I know something I can get for you. Wonderful.
Okay. This is an interesting article, which is kind of redundant. They suggest that black plastic utensils are killing people in the article. What happened is they really found out that that wasn't true, and that plastics aren't particularly great, but whether they're black or not is not the issue. And that they had made a medical error, mathematical error, and that they had disseminated information that wasn't accurate, and that black plastics were not different from any other plastics in terms of causing harm. And of course, we know that plastics have their own problems, which we've talked about recently, about finding plastics everywhere in the body, including the brain. And so we know that plastics have their own issues, but the blackness of the plastic is not the source of the problem. That's what this article is all about, that identified black plastics as being a source of lethality. But apparently this was not correct. And this article is correcting that misconception. So black is good for making money. You're in the black, and uh, black utility uh, products are not bad. That's the moral of this story. John Buchanan.
Yes, Dr. Callender, as an adjunct to this article, um, a lot of the uh, utensils that we use when you eat out, they have plastic spoons and forks. All of the pottery that you get, the cookware, a lot of it has the no stick surfaces. I'm very concerned about those surfaces, where really tested them to see how safe they are. Um, as far as getting plastic and other uh, potentially lethal chemicals into your system through your cookware, your fry pans and pots and pans. Some of those non-stick, Teflon. Wonder about all of that. Whether we should be uh, doing studies about that. Anybody know?
No, I think it's very clear we need to be studies about it, but I don't know that any have been done yet. But they may be in the process of being done. But I think your caution is appropriate, and it's something that needs to be tested, because we're now finding plastics everywhere in our bodies. So that this is a potential source of harm that does need to be studied. Any other comments? If not, we'll go to the next article. This is a drug that everybody knows that obstructive sleep apnea is something that is cause for hypertension and uh, death and many other complications. And up until now, the gold standard has and continues to be uh, use of machines that allow you to sleep, CPAP and other things like that, including certain operations that are done for obstructive sleep apnea. And they're effective at reducing complications from sleep apnea. But now we now have an FDA-approved drug that also is not necessarily the gold standard, because it's not, but it is something that can be used. And the studies demonstrate that it, particularly with people who are obese, is effective at reducing the amount of obstructive sleep apnea that you have. And this study it's an interesting drug that has been used that has just been approved. The tragedy is that 85% of obstructive sleep apnea cases are undiagnosed. And so people develop the complications of hypertension and other significant and death without realizing that they have sleep apnea. Many of the patients with sleep apnea are obese, but there are many who are not. And, and, and this is a drug that can be added to the armamentarium of those people who have sleep apnea. It's the first successful drug that has been used now. We know that there also is an operation for sleep apnea where they deal with the phrenic nerve to allow to deal with obstructive sleep apnea. But whether this can be as effective as CPAP and the surgery for the phrenic nerve situation remains to be seen. And keep in mind that many patients for whom CPAP can be used cannot have that operation for the phrenic nerve, which avoids the use of CPAP. But that operation can only be done in a certain percentage of patients. Any comments about sleep apnea and the fact that there's a new drug that is somewhat effective at treating sleep apnea? Just wanted you to know about it.
Quick question: is that tirzepatide? Is that one of those GLP?
I think it's related. They didn't say so in this article, and I was looking for that, but I think it may be in some way related, but it does not say so in this article.
Yeah, it'll be coming up soon. Okay.
The GLPs, yeah.
Yes.
Right.
Here we go.
And the situation with this is that because of the shortage of the GLP drugs, people were getting compounds that had semaglutide, and they were medicating it and adjusting it according to their own computations. And these dosing errors cause many side effects and overdoses. Uh, um, it is alleged now that they have enough of these glutide, glucogen drugs that you don't need to get the compound and administer it yourself. But that, of course, was the biggest problem. The fact is that these drugs were initially used for diabetes. Then they found out they were effective at treating obesity. And so the obesity market is huge. And as a consequence, many of the diabetics couldn't get these drugs. And so they had to get compounds, and the compounds, they had to figure out exactly what kind of dose would be appropriate. This no is theoretically is no longer the case, and John has highlighted the side effects that some of the patients had who took too much of the GLP drugs, and they allege now that there's enough GLP drugs so that you don't have to worry about giving yourself the compounded forms of GLP drugs. And so the recommendation is to stop using the compounded forms and get the drug at a dose that is appropriate for you. Now, whether this is the case or not, I'm not sure, but the FDA has suggested that there's no longer a drug shortage of the GLP-1 drugs. This is a drug that, as you read here, was first approved in 2005 for type 2 diabetes, but the market for obesity was so huge that the diabetics couldn't get it. And of course, there are more type 2 diabetics than there are type 1 diabetics. And this then produced a tremendous problem for diabetics. And that problem now is thought to have been overcome, and they have enough GLP-1 drugs. Now, as we know, the GLP-1 drugs not only have been effective for diabetes and obesity, but also for addiction, and for some people think it's for Alzheimer's and for other for liver disease and other aspects. So it's become a wonder drug that we should all know something about, because it's so common, so that you, your children, great grandchildren, great grandchildren may be using these drugs for different issues. But taking it safely becomes an issue. What happened is that they had these drugs online, but these drugs that were online had to be compounded by the patient themselves, and that led to the problem. And this is another drug that has been effective for weight loss and preventing diabetes progression at 3 years, which is remarkable in the sense that to prevent diabetes progression at 3 years, to have that to be confirmed by studies is something that is remarkable. And this tirzepatide, the same drug that we talked about earlier, is the body weight and glycemia and having a long-term benefit. So this is important to know about it for those people who type 2 diabetes and those people who are obese. It's much more effective in those patients who are overweight. And as we know, with type 2 diabetes, one of the best ways of treating it is to lose weight. And so this is why this is important to share. And these studies demonstrate to highly statistically significant degree that the normal glycemia and the reduction in body weight were remarkable. Dr. Perez?
Do you think that we are going in the direction that people with type 2 diabetes who have been controlled with diet and exercise are missing some of the protective factors that we're finding associated with people who use the GLPs in terms of treating their diabetes? If we're calling one issue, you said market for obesity is tremendous, but so is dementia. And if GLP-1s are preventative, or we're seeing the decrease in the onset or the retardation of the onset of dementia in patients who use it, should people who are controlled by diet and exercise begin to get some of the preventive benefits that we're seeing associated with GLP-1s?
I think that's a great question, but I don't know that we know the answer yet. And I think we need more studies but I think that's a great question. And I think it probably takes a little more time. But this study makes you think more about whether or not there is some aspect of quality of health that is lost by not having these drugs. But then the question is a drug better than no drug at all? And that's the question I don't know the answer to. But you raise a very important question that needs to be answered. But I'm not sure we've got the answer yet, because many of the studies that allege that these drugs are good for addiction and for uh, Alzheimer's, et cetera, haven't stood the test of time. We see it with the diabetes and weight loss, but we haven't seen it for the test of time with the other things. Many of the things that we now are identifying are really recent, and so long-term studies would help answer that question. But I think your question is very timely and appropriate, and food for thought.
Dr. Callender, is tirzepatide, is that an injectable? You have to self-inject it?
Well, just about all of the GP1s are injectable. Yeah.
And do you have any idea the cost?
Yeah, they told us the cost. I think we shared that in one of the recent articles. Uh, it's covered by Medicaid, but I think it was still was some couple of $1,000s a month. But I can't recall. There was a recent article that actually answered that question, but I don't recall exactly how much it was. But it did identify that Medicare would cover it, and that there was a certain amount of charge above the Medicaid cost, but I don't remember what it was. This is another GLP-1 agonist that improve their quality of life plus weight loss, which causes us to address the question that Dr. Perez brought to us, which is this going to be better than just losing weight? And that's a good question. I don't know the answer to it. These recent studies suggest that there's more to it than we know, and that there's side effects that are very positive that you would be missing if you weren't taking these drugs. So, especially when you have a drug that has so many benefits, when you see that prior to the use of this drug, they didn't have any medication and that would successfully treat non-alcoholic related liver disease. And these GLP agonists actually modify and actually treat a formerly untreatable disease. Dr. Brass?
I think this speaks so much to how important it is we Black people be part of clinical trials and finding ways in which our inclusion in this trial change to better health outcomes for our people. Whether it's whatever that might be, but it's critical that we be in these trials.
Well spoken. Well spoken. Any other comments or
A
questions?
question, Doc. Disinhibition. What is that right here? Hunger and disinhibition.
This is, I think, disinhibition relates to addictions, but let me look it up to be sure. I'll look it up for you.
Okay. Here's another one.
Yeah, and they're all addressing the same issue that Dr. Perez is pointing out. That it's in many ways you'd have to consider this a wonder drug.
Until it's not. we thought plastics was a wonder.
Yep. That's right. It says disinhibition is inability to withhold inappropriate on one year. So it's addiction and those kinds of things. That's what disinhibition is. And it looks like it. But I think Dr. Perez pointed out another thing. We thought plastics was wonderful. So now we see that it's not so wonderful. But anyway, so far, it's looking like this is a wonder drug. So with time, it may turn out to be just that. But right now, we don't. And we know it's effective against chronic kidney disease, liver disease, and you name it. So it's something that we have to be aware of and be knowledgeable of so that we take advantage of it as soon as we know that it is beneficial above and beyond just losing weight. So it's a very, very good point that Dr. Perez has made that we have to keep in mind and keep looking out for studies. And as she pointed out, we need to be particularly part of the clinical studies so that we know that these things apply to people of color as well as people who are not of color.
One thing that you said, Dr. Callender, and being the phenomenal physician that you are, surgeon, you said we need to be knowledgeable. And that's important, but culturally, the relationship between patient and physician was that you trusted your physician to provide the pathways of therapeutics and strategies that were best for you. And now that relationship has been compromised by many things. But the decision to request medication and to request therapies by patients, I know for me that was not a burden that patients had to bear. And the culture has changed. Would you agree?
Couldn't agree more. I think that right now, for example, it is expected that the physician shares his information with the patient, and the patient makes the decision. So that we've gone from a situation in which the physician made the decisions to a situation where the physician presents the information to the patient and the patient makes the decision. So that the patient is now the focal point of care, and the physician does the best he or she can to educate that patient so that they can take advantage of the knowledge that he has and they have, and then let the patient, so that the patient-centered care is a new modus operandus, which was not in effect 10 to 20 years ago. The patient heard the doctor and followed the doctor's advice. Now, the doctor gives the patient all of the information and the patient makes the decision. So it's patient-centered care, not doctor-centered care or nurse-centered care, patient-centered care. Mr. Buchanan?
Yes, Dr. Callender, the patients are watching football games and basketball games, and every other commercial is about one of these GLP-1 drugs. You know, they say, ask your doctor, you know, please. I mean, seriously, and every single one of them says that they're miracle drugs. So what are we gonna do? We're getting bombarded with information, and we need to make decisions. So we need the doctor to help to, part the Red Sea and figure out what's going on for us.
Well, I think that increases our responsibility as physicians to be able to understand that we have to have the information at hand. If we don't have it, get it, and then share it with the patient so that the patient can make the best decision. But we still have that responsibility. But when push comes to shove, the patient is the person who is the focal point of care, as the person who has to make the decision. We as physicians have a responsibility to get that information, but we must share it with them and then let them make the decision. Now, very often they will listen to the doctor and say, "Doctor, what do you think?" And then the doctor will tell them what they think. But the point is that the decision making is really by the patient, with the doctor being an influential part of that decision making. Mr. Tatum.
Yeah, back to the point of being bombarded with all these different kinds of medication, everything comes a list of all of the side effects, which really
Yeah.
further complicates things for the patient-centered care because the patient now has to decide which of those side effects are going to be tolerable, and different side effects work differently on different people. So it just further complicates everything.
But then life is complex. So we as physicians are supposed to try to simplify it to the point that, and that's our job, do the best that we can. Life is complex. And so, yes, it is complicated. But in this day and age, yet and still, the doctor has a responsibility to reduce it to its simplest forms and then allow the patient to make the ultimate decision. Dr. Perez. Dr. Perez, did you have?
The other issue in that conversation, because there were some healthcare professionals who told Big Pharma this was a direct-to-consumer advertising was a bad thing. But hearing you, Dr. Callender, another component to this conversation is cost and insurance. So that making the decision, I might say that strategy A is the gold standard, but your insurance will only handle or be able to take care strategy C. And in making your decision, are you making a decision for you and for your family's wealth? Because the impact of certain decisions can come down to money.
Well, one of the tragedies that makes things so complex is the fact that many of the uh, institutions that are supposed to be helping patients will only help you if you have insurance, and which means that a segment of the population is excluded. And that's why our system that doesn't have a universal health care is problematic. And that's why to really have access to all, we need to have a system that gives us universal health care, which we don't. And so until that is taken care of, we have a complex system, which is further complicated by the fact that we don't have universal access. And therefore, we have a lot of people on the outside looking in, and we think we are being fair, when in point of fact, we are not. Any additional? This is a very important discussion. Any other points of view? Well, hearing no further discussion, I guess it's so complex that we decide to leave it alone. But
I I have it into because we do know this research might be about 10 years old, but we do know that it was shifting in terms of opinion. Doctor, what is your opinion? What do you think we should do? And that opinion from physician decisions has gone to faith care leaders. And so, especially for our population, should there be greater outreach to faith care providers with this information and with sessions like this, journal reviews with clergy, so that when they are asked, they are more knowledgeable, since the research has shown that more patients trust their clergy than they do their physicians.
well, they're good clergy and they're bad clergy, just as they're good doctors and they're bad doctors. And so I don't know that that question is answerable. I just think that uh, I think it really is up to when the patient is not comfortable with the decision, they should talk to the clergy and get help from them. But I don't think that they should necessarily choose one over the other. I think that one of the things, if we are truly um, accept God's will, and we would then pray about it and speak to the Lord about it, and speak to the doctor about it, speak to the minister about it, and then make our own decisions based upon how we live. But I think that you bring an issue that so far is complicated, but is something that, one of the things that I used to always smile about was that the person who came to see me, who had the largest Bible, was the person who had the least faith. And that always used to be interesting to me. That and so I never got an answer to that question, but it was something that always plagued me in many ways. I said, "Wow, it's amazing. Those who have the biggest Bibles seem to have the least faith in them, are the most frightened." But I think that your question really depends upon your own faith and your own belief system. If you really believe in your faith, then your decision about what the doctor says is going to be influenced by your own faith as well. And so that you can't do one without the other. It's a combination of all of the above. Is what I'm saying to you, and that you and your relationship with God becomes a very important aspect of what decision you make about your health. Carol?
Ask the question also to point to what it is that our inclusion in longitudinal clinical trials and investigations, what does our community get back? And just as the federal government, my experience with substance abuse, we then were able to secure time. We paid the institutions to teach doctors specifically about substance abuse. Should that be an ask when we are included in clinical trials? That's a policy issue.
Carol, you had a comment?
Yes, about trusting the clergy more than the doctors, according to what denomination or what cult it is. Several of the Protestant communities, they trust the doctors more than the clergy, especially if, except for counseling. But if it comes to medical work, which is physical, they usually trust the doctor more than the clergy. And the clergies usually decline to say what they're going to do. But I'm thinking of not cults, but the religions that say no transfusion and etc., where they make statements like that. Do they trust the clergy? But by being Protestant most all of my life, I'm saying that they do not, I don't think clergies even try to say anything about the physical work. What were you talking about, Dr. Perez, when they say that they trust clergy more than doctors?
It was a study that the National Medical Association had done. Well, no, it wasn't done by the National Medical Association. It was a study that asked patients, I think there were 3 different categories: family, physician, clergy. And the specifics of it was, who would you trust more with a health decision? And I wish I knew better the specifics of it, denominations, sex, and all of that. But I don't. I know that the outcome of that study was that more people were trusting information from their clergy than they were accepting information from their physicians. And I said that just as a trend, because if we're asking people to make decisions and informed decisions, they have to be informed. And the people that they're getting their information from have to be informed too, so that you can make a reasonable decision. So, should pharma, just as they're putting out all of this information on commercials and things like that, and that's billions of dollars, should an investment be made to make sure that clergy, as they are being trained, are informed on health issues?
Well, that's an interesting question. I personally don't think so, but I think, and I don't necessarily agree with the study. That's one study. I'd like to see a number of studies, because I think that, and again, I go back to a comment I made before, is that if you are truly religious and you really believe in relationship with the master, then you, the master, and the physician might factor into the decision-making process. And then, of course, as you're led to talk with the physician, with the clergy, but the clergy would have to be informed. And of course, that's what you're talking about in terms of taking the monies to educate all of the clergy. To me, is almost an impossible task. And so, I think one of the things that really is required is that the people who really believe in God should really trust in Him and include Him in their prayers and include Him in their decision making. And that may be the best alternative. Since we don't even have universal health care and don't have equal access, it's not really. I think the first thing we need to get is universal health care, frankly. And the other things could fall into place. But notwithstanding all of that, still, you have a personal relationship with your God and you have a personal relationship with your physician. And you can then use both of those institutions, God and your physician, to help you make the decision. Mr. Tatum, you had a comment.
Yeah, I think that depending on your faith and your belief, God has universal health care.
You said who has
Amen. Amen.
God has universal health care if you need.
Well, I don't know that that's the case. I don't believe that. In other words, let's face it. Let's look back at the days of yore when Christianity began. They tried to have universal, and what happened? It didn't work. And so there is no universal health care in this country. And so you can talk about God, yeah, but when they tried to do that, they did not appreciate it. People were lying and doing all kinds of things, and so that was abandoned. So we do not have. You said God has. Well, God has always had that, but that does
Okay.
not apply to what happens in the United States of America,
Oh
where
no.
there is not universal health.
Oh no, I wasn't talking about. I was talking about God alone.
Yeah, but we're not in heaven. We're in earth in the United States of America, where there is no universal health coverage.
I just have one more statement. You cannot go by the premise about a clergy being all and in all. If you go from different denominations, there are some that just come up. The Lord touched me last night. They're no study. They barely can read anything, to the ones that have PhDs, but they go by one person, for instance, a pope, whatever they say goes, and they only have training. Even pastor of churches of the Christian denomination, they go from one array to another. So to put that on any minister, that's ludicrous. But to say that they can train, I have seen them from second grade level to PhD. Some are very intelligent, but they have too many roles to do. And to put a medical role upon a doc on a clergy, if you know how much training they have to go through, what some go through and some don't, according to what denomination, even how they're ordained, we're building it too much. It used to be a time during our slavery time when that was the only person that could read, but we have progressed so far, even during that time, to put that upon the shoulders of a clergy. You wouldn't put it on a lawyer or any other field. So don't put that on a clergy. And all of them go by their own doctrines and etc. So, and in America, we seen by this last epidemic, clergies don't have anything to do. They'll put everything on my religion. I can't take the shot because of my religion. Political people, politicians have more, you know, bearing upon what people doing and everything. Now we're swayed by every little wind, media, and everything else. So just don't say that. I guess I get upset when they say about clergy because I've seen them from one array to another, from one denomination to another. So that is one field, even though we say we're religious, but like Dr. Callender said, some of those with the biggest Bibles, they haven't even cracked it open. They don't even know what Genesis 1:1 says, but they got those big Bibles and they collect dust.
Well, it's a great conversation. Janice Stevenson.
Yes, Carol, I believe and I support the same thing Carol is saying. I think she took it to that next level, but I think we all need spiritual support. And here lately, when I go to the doctor, I always get this phrase, at your age. And it's true, as we age, we have more medical problems, but we also need that support to help us understand and accept, not even accept. I think the main thing we have to have is faith in our doctors. Spiritual support, number one, but have that faith in your doctor. If you're going through a health issue and you see the doctor and you walk away and you still don't feel good, you don't feel you can go into that surgery or that treatment and come out healthier, see another doctor. It's important to be comfortable with your physician. It's important to believe what he's saying is going to heal you, so to speak, but definitely put you on the path of getting better. And the two work together. I truly believe in the spiritual support, but you got to have faith in your doctors. And so many of us go to a doctor because he's my doctor. I mean, what am I supposed to do? You know, if you don't feel well, you go to another doctor. You trust another specialist. That's my take on it. There are a lot of faith healers out there, but I think we all believe in some sort of God, and most of us go to a church, and you go to that church because you feel good when you leave out Sunday morning or whatever you go. But it's important to have that relationship with your doctor. I think the two goes hand in hand. And if you go to church and you feel good and you go to that doctor and you got nothing out of it and you're still just as afraid as you were when you went in, see another doctor.
My only comment finally is that don't forget your relationship with your God yourself.
Mm-hmm.
It's because, and that's what I'm saying that supersedes almost everything else.
Yeah.
Is that you should have a relationship with your God that allows you to speak to that God above and allow you to make a decision as to whether you should share that decision with your clergy, with your family, with your physician. And then when you pray about it, then you make the decision based upon the combination of spirituality and the physician's recommendations. And it's a complex issue. That's why we've had this discussion for so long, because it's a complex issue that a lot of it depends upon your relationship with your God and your relationship with your physician, as well as your relationship with your clergy. So all of that together allows you to make a decision about what to do with your health. And some people, when they get a disease that overpowers them, they then decide to go and do whatever they're led to do. Some will go to faith healers, some will go to another country, some will go. And then there are those who actually believe in their God, and they go to the God and they ask for his help and his recommendations, and they follow that. Now, that's something that's easy to say, hard to do, but that's what I think becomes something that an individual has to make a decision about. The faith in their physician, their faith in their God, and the faith in their ability to follow God's will in all aspects of their lives. Any other final comments?
I have just one more, And I agree with Dr. Callender and Janice. Only except Janice, I think the word when you say faith in a doctor, um, other generations, the generations before us had blind faith. And whatever that doctor said, they couldn't recognize a quack if they saw one. They could say something atrocious, and they're quacks. Our generation, we're becoming a little bit more aware, especially generation under us, that they I don't know what word we should use, but when you ask for a second opinion, means that does it mean you just lost faith with what that doctor said, or you want to have something to verify what he just or she just said? Because there may be something else, and there always someone else that can have a better solution, or because you can't put everything on one human being like a clergy, even a doctor, but our generation and generations under us are now beginning to question things rather than just take that blind faith. Whatever you say goes.
Mm-hmm. Any final comments before we go to the next subject? Thank you for a very fertile discussion on a situation that is very complex, but yet can be made simple in some sense if you really believe in the God you serve and you also have faith in the doctor that you have, and you are so willing, as Carol had said, to get a second opinion. Second opinion doesn't mean you have lost faith. It just means you want a second opinion. Right. And then if you make that second opinion, you may go back to your doctor or not. But I think it's a complex issue, but most of it is resolved if you have the ability to have faith in God, have some degree of faith in your doctor, but be willing to get a second opinion when necessary. Okay, we'll move on to the next case after such a rich discussion. And this is a funny case that we have a new weight loss drug with no side effects, but this drug is not working on humans. This is a drug working on rats, and may well be good for humans, but we don't know. So the moral of the story is be wary of anything that people tell you is good until you know the whole truth of the matter. And we shall see whether that drug which works with the rats is going to work with humans, and we don't know, because so far every drug that we've used has some side effects. Daryl is with us. How about that? Hey, Daryl, how you doing?
Hey, Happy New Year, everybody.
Thank you.
Yeah, my comment is most health insurance plans will pay for a second opinion, but that's important to realize that it's most, it's not all. So check before you get your second opinion.
It's a good point. Good point. And then be willing, if you want a second opinion, to pay for it. That's the other aspect of it. Yeah. Okay, let's go to the next article then. This is just an article that most people who are over 65 are on some medication or another. And one of the drugs that many take are the statins because they lower the cholesterol level, and they are thought to be very beneficial to your health. However, this study finds that there's been an association between the statins and the increase in your intraocular pressure, which can damage your eyes. And so this means that those of us who are on statins, that you should get an annual check with your eyes to make sure that your pressures in your eye are normal. And if not, then that requires treatment as well. But this is one of the more recent studies that has identified that there is a higher risk of glaucoma, which is an increased intraocular pressure that can damage your retina and make you go blind. So just sharing to let you know. So make sure that if you're on the statin, that you get your eyes checked at least once a year, and they look at your intraocular pressure to see if you have elevated pressure, which is glaucoma or not. And if so, that can be treated as well. Glaucoma is a particular frequency in the people of color, and so it's important to recognize this and be sure that you see your eye doctor once a year. Any other questions or comments about this particular article? At least you should be aware of that. Next article, please. This is an interesting article that we may have discussed in the past, but it has new guidelines in the sense that if you don't have urinary symptoms, you shouldn't be doing urine cultures or urine tests, because if you don't have urinary frequency or burning or anything else, then you may have asymptomatic bacteria in the urine, which does not require treatment. And so they then saying if you have patients who are asymptomatic, there's no point in getting urine cultures. If you have symptoms, that's another story. Because you have symptoms, you have burning, you have frequency when you urinate, or you have blood in the urine, or you have cloudy urine, then those are reasons to get cultures and to treat patients. Then when you treat them, they mention the drugs that you should be using should be Bactrim and Parenteroin, and drugs that do not expose you to antimicrobial resistance, because that is one of the ideas that is going to be the number one cause of death in the future, is resistance to drugs. And using drugs like Bactrim or Furantoin is less likely to be associated with antimicrobial resistance. And so the moral of the story, they also talk about cranberry juice and other things that and drinking a lot of water, which are likely to reduce the likelihood of getting urinary tract infection. And for women, topical estrogen is mentioned as well. So this is something that is recognizing that in the future, one of the most likely causes of death from infection will be antimicrobial resistant. So therefore, you don't want to waste or use inappropriately antibiotics that will result in the future developing resistant strains of bacteria that will be resistant to the antibiotics. So it's going back to the old drugs, Gantracin and Nitrofurantoin, which are drugs that are not antibiotics in the strict sense of the word, that will lead to antimicrobial resistance. Dr. Perez, first, and then
What I think it's so important what you said, because again, it might be cultural. As a pediatrician, I know there were many parents who left that felt that I was an inadequate physician because I did not give them an antibiotic for their child that had symptoms, upper respiratory symptoms. And for our people, it's going to be very important that we spread that message, because it's easier to write a prescription than it is to explain a viral infection. And so we may, being the disciples of Dr. Callender, spread the word to the community that we don't need antibiotics for everything, and that we need to be immunized so that there is not a possibility to think that something that is causing symptoms is a disease that we've already been immunized against. So for our community, I believe it's very important to bring the discussion down to a family level that we can talk about it.
Daryl?
Yeah, eating cranberries is the most healthy option. 100% cranberry juice is less healthy, and cranberry juice with added sugar is the least healthy of your options.
Thank you for sharing. Any other comments on this article, which is far-reaching in terms of, and it goes back to some of the things that Dal has talked about in terms of the way in which animals are prepared for use for meals, and they're given antibiotics and other things, and this predisposes to antimicrobial resistance, which is fearful of becoming one of the leading causes of death from sepsis in the future if we aren't careful about the abuse of antibiotics. So, any other comments? Thank you for sharing that information, Dr. Perez and Daryl. Any other comments? If not, we'll go to the next article. This is an article that makes us become aware of the fact that people who have cancer and have antibody drug conjugates that is now commonly used in the treatment of cancer, that they develop eye toxicities that can lead to blindness. And so those people who are on those multiple antibody drug conjugates need to be sure that they see their eye doctor as well. We mentioned the issue with the statins. The same kind of issue can be said with the antibody drug conjugates, except that they may involve the cornea and other parts of the eye that may lead to blindness. And so those of your relatives, friends, others who are on the more advanced treatments for cancer need to be sure that they see their eye doctor to make sure that they don't develop any of these ocular toxicities, which can damage different parts of the eye apparatus. Any comments or questions about this, which is a little complex, but I've broken it down so that you could understand what they're talking about. Nowadays, with the treatment of cancer, we use a number of antibody treatments, immunotherapy treatments, and that are very effective, but also have side effects. And one of the things that is common that I don't know of any drug other than perhaps water, which and air sometimes, which does not have side effects. Move on to the next article, unless there's a comment about that. That's the last one. Good. Okay, we made it. Finally finished. First time we've done that in a while. Thank you for those of you who returned to us to start the year off with us, and thank you for the very fruitful discussions we had today, which were very, very fruitful to hear different sides of the story in terms of who to trust and how you go about maintaining your health. And so we've had some remarkable sharing today. Good to see you, Mark. Happy New Year to you, and Happy New Year to everybody. Dr. Aton, good to see you too. Dr. Perez, any comments that you want to make as we get ready to start the year off right?
I love you. And I love all of you. I'm very excited about this year, and your shares have so enriched my life, so that I will be around for my grandson who's coming in April.
Congratulations.
Yeah, congratulations. Now, many of you may not realize that January the 28th will be our 50th anniversary of the existence of this transplant group. I guess I'm the only one who's been around for those 50 years. But we may start thinking about how best we can celebrate the 50-year celebration. I'll try to get some people to speak with us who maybe we haven't had before, and some we've had before, as we celebrate the 50th year of transplant support group.
Oh, Dr. Callender, we can't have a party at your house?
Well, I don't know. Well, it's food for thought. I mean, I think we should think of ways in which we could celebrate. So
So that means we should form, I got one organization, several other organizations. So we always form committees that will plan it so you wouldn't have to do it all by yourself.
Well, I think that's
appropriate. I'm in.
That's 2. Janice, you 3. Women take over.
I know.
Well, you saw what Eve did, so keep that in mind.
I was thinking back to when we met in person at the hospital with breakfast.
Yeah.
Continental breakfast. I
really I remember those days.
I was there for that. I remember that.
We had 4 articles, maybe, hand printed by Dr. Callender.
Yeah.
You're going way back.
Yeah, that's right. Well, that's that. But way back is when Tatum and David and others were.
Well, I was